Well, greetings, everyone. Welcome to the EMedHome EMCast for November 2014. This month, we've got an incredibly important EMCast for you. We're going to start things out by talking about low-risk chest pain, kind of a misnomer in many ways, because what traditionally is thought of as low-risk chest pain is actually relatively high-risk. It's a high-risk topic from the standpoint of medical legal issues and misdiagnoses, and it's something that worldwide emergency physicians and to some extent cardiologists also lose sleep over. They stay up all night wondering about. We wonder about that patient that we sent home. We dread the words, hey, remember that patient with chest pain you saw last night that you sent home? That never ends up good, right? It's something that we all think about all the time. Well, there is new literature that's been coming out over probably just the past year and a half now, which has finally been validated and is helping to justify some new concepts with regards to how we work up these patients, and also helping to support the idea that we don't have to do a full court press workup all the way down to provocative testing and sestamibi and stress testing for these patients, but maybe we can evaluate the patient and to a large extent obviate the need for further workup with just some basic workup while the patient's still in the emergency department. I'm going to go through a bunch of articles, especially some very, very important recent scoring systems that are helping, I believe, change what will be the standard of care with regards to how we take care of patients with low-risk chest pain. And it's not just my opinion that I'm going to be expressing. I'm going to be expressing opinions that have been based on some really good articles that have been coming out recently, as I mentioned, over the past year and a half. Then we're going to move on to another very relevant and high-risk type of topic, and that is airway management in the victim of trauma airway management. This is a high-risk scenario in terms of blood and trauma and difficult airways, and you got collars to deal with, and, well, there's some new pearls, relatively new pearls that were new to my ears at least, that can help when you're taking care of these tough airways in terms of getting the tube in, what kind of things should you do, and also some interesting things that I traditionally would do that I'm not going to do any longer. So we're going to spend some time talking about an article that pertained to managing the trauma airway. And then we're going to wrap things up with a shorter segment, but an incredibly important topic, and that is informed consent and informed refusal, once again based on an article that was just recently published in Academic Emergency Medicine. This has big-time legal implications. There are still a lot of lawsuits out there for failure to provide proper informed consent and failure to administer proper informed refusal. This is something that everybody out there needs to know. If you're a resident, you need to know about this. If you're an attending, you need to review this and make sure that you're doing it the right way. So 3 topics, all are high risk and very, very important. So buckle up and we will get started with the November issue. All right, well, to kick things off this month, I want to spend a little time talking about low-risk chest pain. There's been a lot of literature coming out recently about some scoring systems for chest pain, and I think this has become, once again, a very timely topic. And so let me just preface all of this by saying that this is a risk management discussion. This is not intended to be a clinical or best practices, how to take optimal care of patients type of discussion. And frankly, for anybody out there who is board certified and well-trained in emergency medicine, chances are what you're doing with your chest pain patients is really good already. And you can do anything that you want with your chest pain patients. The reason that we sometimes will discuss this, the reason that I discuss this, is because risk management has become a big part of what I do. And I have a lot of concerns about the risk, especially in the United States, but the risk that the legal environment has brought to the careers of many emergency physicians, including many listeners, including people I know whose lives have been very affected by the medical legal system in the past. Going back to some of the things that I've recommended and talked about in the past, we've talked about the National AHA guidelines, which are a bit puzzling. I don't necessarily agree with the guidelines, but I think everybody, especially in the U.S., who is in a very litigious environment, needs to... and by the way, let me just sidetrack for a second. We always talk about the U.S. being very litigious, but it's interesting that just over the past 4 or 5 years, I've noticed friends up in Canada and also some people out in Southeast Asia and even in Europe who have been emailing me frequently about the increasing litigation that's occurring even in those places. Some people may debate that, but it's my impression that lawyers are leaking out from the United States and going out into other parts of the world and messing up the environments out there as well. So I think this is probably not just a U.S. problem, this litigious environment. The problem that we have as a baseline has to do with the fact that probably over the past 10 years, the ACC-AHA guidelines have always said that if you have a low-risk chest pain and you have some level of concern and you open the door to a workup and you start sending off troponins on that patient, you now are obligated to carry that workup through to completion. And what the guidelines say is that you need to do some type of provocative test. You can do a sestamibi or a myocardial perfusion imaging test right away in the emergency department, but if you don't have access to that, then you need to do a provocative test like a stress test. And we're not going to go into the details of the different types of stress tests. They simply say you need to do some type of stress test, or you can do a coronary CTA as an alternative. We're not going to open up that Pandora's box right now, but that's what the guidelines say. You either do the myocardial perfusion test or the provocative test or the coronary CTA. But the workup doesn't end until you've done one of those tests and the test has come back negative, and then you can call it quits with regards to the workup. Now, the guidelines do say that the provocative test can be done at some point within the next 72 hours, so it doesn't have to be an admission or an OBS. It can be a patient that gets discharged as long as the provocative test ends up being done within the next 72 hours. And they specifically say preferably within 24 hours, and that can be done in a patient who meets low-risk criteria. One of the problems that we encounter is that nobody had previously really come up with a good set of low-risk criteria or a validated set of low-risk criteria. Who exactly is it who qualifies for that 72-hour outpatient workup? That ends up being argued because of the lack of good studies describing who meets the quote-unquote low-risk criteria for outpatient follow-up and workup within 72 hours, unquote. And I'm going to say it again, this is a risk management discussion. This is not a best practices discussion, because at this point, I'm sure a lot of people out there are saying that the overuse of stress testing is probably neither sensitive nor specific, and is probably leading to an increased number of workups that is causing more harm to patients than good. And I'm not going to argue that point. To a large extent, I really actually agree with that point. But this is risk management. And the fact is that the guidelines say what I just expressed. And if you end up discharging somebody who didn't get one of those workups and they have an adverse outcome, then people are going to throw those guidelines at you. And I've seen it happen over and over. If you don't believe me, you can talk to some of the risk management experts that are out there, Greg Moore and Greg Henry and Larry Weiss and others who have seen this happen in deposition and in court. And I've seen this at depositions also, where they will simply have the physician read the guidelines into the deposition, or they will have the physician read the guidelines in a court to the jury, and then you end up looking very foolish because you didn't follow national guidelines. And when they say, why didn't you follow national guidelines? Well, the only way that you can really justifiably convince the jury that not following the national guidelines is reasonable is you have to have some type of published data. And there really, up until 2013, 2014, has been no validated, prospectively validated, published data that says that you don't have to follow these national guidelines. So as an example, let me tell you exactly what happened in one case several years ago, where a physician had a relatively low-risk patient, sent off 1 or 2 sets of troponins that were negative, and discharged the patient. The patient ended up having a bad outcome. A lawsuit was brought against this emergency physician, and the attorney pulled out these guidelines and said, Doctor, here's the ACC-AHA national guidelines written by world-famous cardiologists, including an emergency physician that's listed as one of the authors. There are multiple national organizations that have endorsed this document. There's 150 references in this document. Show me the literature. Show the jury the literature that says that you do not have to follow this set of guidelines. And again, up until 2013, 2014, you would not be able to produce prospectively validated literature saying that you can not follow the guidelines. On the other hand, let's take ACLS guidelines as an example. We don't follow the ACLS guidelines, and the reason that we feel comfortable not following all of the ACLS guidelines is because there's very good literature saying that a lot of the ACLS guidelines are wrong. But when it comes to the ACC/AHA low-risk chest pain type of guidelines, there has not been good validated literature saying that those guidelines are wrong. And despite all the podcasts and the lectures and everything else that people talk about how the guidelines don't make sense, and again, I agree with that, nobody has ever gotten all of the data together and published a good paper or a validated paper that says that the guidelines are wrong. And in my experience, and I'm sure in the experience of many of those other really well-known risk management people in our specialty that I already mentioned, I'm sure in their experience also, nobody has ever successfully brought a podcast into court or someone's tape-recorded lecture into court and said that this lecture, this podcast, is why I didn't follow the guidelines. The fact is, podcasts and lectures don't cut it. You need to have prospectively, externally validated literature if you're going to overturn a nationally endorsed guideline. And that's where our limitation has always been, and that's why I've always been concerned about the way that some of the people are out there are managing low-risk chest pain. And I've tried to defend those people in many of those cases. And I will tell you, it is extremely difficult to fight off those guidelines, if not impossible. And remember that standard of care is based on what you can convince a jury of, and it's a whole heck of a lot easier to convince a jury that guidelines that are endorsed by all these organizations and written by all these famous people are a standard of care when the person who's opposing that has no good literature to base their opposition on. Again, at this point, I'm going to say it again, that I don't necessarily agree with those guidelines, but this is a risk management issue. So that's the problem that we've been fighting up until this point. The fact is that if you want to overturn guidelines, if you want to say why you didn't follow guidelines, it's ideal to be able to show people that you are following prospectively externally validated literature to say why you didn't follow those guidelines. What does that mean? Well, you know what prospective means. You know what validated means. Anybody can come up with any literature that says just about anything, but you want to have somebody try to validate that literature by doing their own study and showing that your ideas worked. And ideally, it should be externally validated. In other words, another group of researchers in another part of the country using different patients in a different hospital, maybe even in a completely different country, validate your study. So prospectively, externally validated type of literature is going to carry the highest weight and be most reliable. And there's many examples of people that have come up with great studies out there that end up not being validatable, or they validate it themselves in their own patients, and then somebody at a different set of institutions or in a different country tries to validate it and it fails miserably. And so that's why I say before you accept something, I think ideally it should be prospectively, externally validated. And that, folks, is what we've been waiting on. So let's move forward to what may be an answer to some of the problems, the medical legal problems that we have faced. It appears starting in 2013, we have finally seen good literature which is prospectively and externally validated, saying that there may be some other ways of approaching chest pain which may obviate the need to do all of these different stress tests that the ACC and AHA are endorsing. And I think most people have now probably heard about the accelerated diagnostic protocols. These are largely protocols that were developed in Southeast Asia and in Australia, that region of the world, where what they did was they took highly sensitive troponins and they got a negative troponin at 0 hours, in other words, at arrival, and then another negative troponin at 2 hours. And if the patient met a TIMI score of 0, then those patients ended up having less than a 1% risk of adverse outcome by 30 days. Adverse outcome means risk of having an infarction or needing to go to the cath lab or get a bypass or dying. So very, very low risk, less than 1% risk of an adverse outcome within 30 days if you have a TIMI score of 0 and you have a negative highly sensitive troponin at times 0 and 2 hours. Now, there have been a couple of problems with that. Number one, a TIMI score of 0 is very difficult to accomplish. And just to recall what a TIMI score of 0 entails. A TIMI score of 0 means that you are under the age of 65 and you have fewer than 3 cardiac risk factors and you have not used aspirin within the past 7 days and you do not have known coronary disease and you have had no more than 1 episode of what's thought to be angina in the past 24 hours. So if you've had 2 or 3 or multiple episodes of angina within the past 24 hours, that is a TIMI of 1. And you also have to have an EKG which does not show any ST segment deviation, and of course you need to have the negative troponins. So it's kind of tough to meet a TIMI score of 0. Some people have said, well, let's get rid of this stupid aspirin thing within the past 7 days. Even then, it's still relatively difficult to meet that TIMI score of 0. And the other problem number 2, is that this uses a highly sensitive troponin at 0 and 2 hours after arrival. These highly sensitive troponins are not yet available widely in the United States. They've just recently been approved by the FDA, to my knowledge, but I don't know of any hospitals that have the highly sensitive troponin. The second issue with the highly sensitive troponins we've discussed before is that highly sensitive means enormously non-specific. They're awful. They are positive in so many patients that what ends up happening between TIMI score of 0 and having these negative troponins, only about 5 to 10% of patients end up meeting this accelerated diagnostic protocol and are therefore deemed acceptable for discharge. Now, 5 or 10%, that's not bad if you can at least send 5 or 10% out and not have to worry about those patients. These accelerated diagnostic protocols, I think, have been a very popular source of study, and people are starting to study and try to validate the idea of having a TIMI score of 1 or maybe 2 and see how useful that is. But again, my biggest problem with this accelerated diagnostic protocol is still this highly sensitive troponin, or the highly non-specific troponin, and I don't know how far we're going to get in terms of being able to discharge people when the main test that we're using is so non-specific. Anyway, I've got my fingers crossed. What I actually wanted to spend just a little bit more time on is a relatively new scoring system called the HEART score, HEART, and it stands for something that I'll mention in just a second. And this has been getting a lot of press. This was a scoring system to be used for low-risk chest pain that was originally created by some folks in the Netherlands, and I think the main authors were Jacob Six and Barbara Backus, amongst a group of others. They came up with this concept of using this particular score. They validated it. It was externally validated by Simon Mahler and his group of colleagues down at Wake Forest. It has subsequently been validated in a number of other countries as well, including the Pacific Asia population, and that included some of the authors from the Accelerated Diagnostic Protocol. So they're kind of blending some of the ADP studies with the HEART studies. The folks down at Wake Forest really deserve a lot of credit because they're continuing to do more studies on this using thousands of patients. They're probably going to be publishing their data, and hopefully it'll be very, very optimistic data in the coming spring around the time of the AHA meetings and the SAM meetings. And this is a really promising protocol. The reason I like this a bit more is for a few reasons. First of all, this uses a normal current generation troponin. You don't need the highly sensitive troponin, but you can use the current generation troponin. Secondly, this has been prospectively, externally validated, and it's been validated in a multitude of different countries now. And again, look at the guys down at Wake Forest for a lot of the upcoming studies, and also the folks in the Netherlands are continuing to study this as well. The populations in which this appears to work includes women, elderly, and diabetics, which are the 3 high-risk groups for atypical presentations, and that's really important in terms of risk management as well. I don't want to go through all of the details on this podcast because I think chances are people aren't going to remember all the details anyway. You can just Google search the heart score and you'll see what all the scoring system things stand for, what all the elements stand for. But just quickly, the HEART, what these briefly stand for, H is for history, and you get either 0, 1, or 2 points depending on how suspicious the history is. The E stands for the ECG. You get 0, 1, or 2 points depending on the magnitude of ST segment depression, 0 meaning normal, 1 is non-specific junk, and then 2 is 1 millimeter of ST segment depression in a couple of contiguous leads. The A is for age, less than 45, 45 to 65, or greater than 65 gets you 0, 1, or 2 points respectively. The R is for risk factors, no risk factors, or 1 or 2 risk factors, or 3 or more risk factors will get you 0, 1, or 2 points respectively. And then the T stands for troponin. 0 points for troponin is a normal troponin. 1 point is if the troponin is a bit elevated up to 3 times normal. And then if the troponin is 3 or more times the upper limit, then that's worth 2 points. All right. So again, HEART, history, ECG, age, risk factors, and troponin. Don't bother trying to remember all this. Just Google search this and you'll come up with the exact criteria. Anyway, what these authors found is that if you have a heart score of 3 points or less, you had a 6 in the prospective validation study. What they found was that at 6 weeks, you had a 1.7% risk of a major adverse cardiac effect. And again, those are MI or need for revascularization or death. 1.7%. We'll come back to that in just a second. Using this score, 36% of the patients met this lowest score. Does that mean that you can send home 36% of the patients? Well, the folks in Netherlands said you probably can. I don't know for sure that in the United States that a 1.7% miss rate in 6 weeks is necessarily acceptable. I will leave that to all of you to decide for yourself. But the other interesting thing about this is that they only used a troponin at arrival. There was no subsequent troponin. Simon Mahler and his folks at Wake Forest, obviously in the United States, said that, well, 1.7% is not something that we all feel comfortable with. And also getting 1 troponin is not something that we feel comfortable with. So what they decided to do was they got a troponin at arrival and they repeated the troponin at 3 hours. And what they found is that if you do get those 2 troponins at time 0 and 3 hours, the risk went from 1.7% down to a bit less than 1% at 30 days. So, again, just to recap that quickly if it's confusing, what they found is that if you have a score of 0 to 3 and you have a negative troponin at time 0 and a negative troponin after 3 hours, current generation troponin, your risk of an adverse cardiac event at 30 days was a bit less than 1%. And that's pretty darn good. Now, the next question that might come up is, are we willing to accept a risk, let's say, of 1%? Is a 1% risk of adverse outcome acceptable to you at 30 days? Well, I'm not going to debate that. Some people might say yes, some people might say no, but I think even the people that say no would probably agree that if a patient has a risk that is only 1% at 30 days, that is certainly someone who is low enough risk to be discharged for further outpatient workup. You don't need to necessarily keep that patient in the hospital. You don't necessarily need to admit that patient to an OBS unit. You can probably discharge that patient to get an outpatient reevaluation and workup if they have that low of a risk. And I think that would meet a standard of care. And I also think that because this has now been externally validated, that would be a very, very reasonable approach. And a lot of these patients are going to be dischargeable. Probably you're going to be able to get rid of more of these patients than using the accelerated diagnostic protocol. I'm not trying to bash the accelerated diagnostic protocol, but as I mentioned before, I think one of the big benefits of the heart score is that it does use a normal current generation troponin. And because, as I mentioned before, the TIMI score is so difficult to achieve, the heart score, in my opinion, is a more reasonable and tenable approach to evaluating these patients with low-risk chest pain. All right, now there's one more caveat that I've got to throw in here. Some of you who were listening carefully probably noticed that the T in heart stands for troponin, and it is possible for a person to have an elevated troponin and still only get 1 or 2 points, and therefore still be considered dischargeable. Would you discharge somebody who's got an elevated troponin? Would you discharge somebody that had a 3 or 4-fold elevation in troponin? Well, according to the heart score, that if that's the only element that's positive, that person still has a heart score of less than 3, and I think most of us would probably not want to discharge that patient. And so you may just elect that if the troponin is elevated, you may simply elect to not follow the heart score. I think that would be a reasonable approach. Or the other thing that you can do is, if the troponin is a little bit elevated, you get the repeat troponin at 3 hours and look to see whether that troponin is heading north. If the patient is having a true MI, you should expect to see at least a 20% rise on that repeat troponin if it's drawn after 3 to 4 hours. And that is according to the 2012 Third Universal Definition of Myocardial Infarction, which is an international collaboration of cardiologists when they got together and defined how we're supposed to define myocardial infarction. 20% rise in troponin after 3 to 4 hours. If instead that repeat troponin is just kind of smoldering and not heading north, then it probably is one of those false positive causes of troponin, and instead it may predict a different thing like congestive heart failure, pericarditis, myocarditis, sepsis, stroke. I mean, there's so many different things that can give you a bump in troponin that do not rise 20% within the first several hours. You know, granted, most of those things that bump your troponin that are not ACS are still things that we're going to admit people for. And so as we're putting this protocol together in our own network of a dozen hospitals or so, I think the direction that we're heading is that we are going to use the heart score, but if the troponin is elevated, we're probably just going to go ahead and admit that patient anyway, regardless of what the heart score is. And I know of another major, very large emergency department system nationally that is taking on a very similar approach, that they're going to use the heart score. But if the troponin is positive, just don't even bother with the heart score. Just bring him into the hospital. Again, it's your choice as to what you're going to do with that troponin. But I would be very conservative if the troponin is elevated. Using this heart score with the 2 current generation troponins that we've talked about, how many patients are going to be discharged or dischargeable? It appears, based on the early data, that maybe as many as 20% of patients are going to be dischargeable to continue an outpatient workup and therefore not need to be admitted or even obsed if you use this heart score and the 2 troponin approach. And that's pretty darn good. If you can get 20% of your patients discharged, especially now with the current Affordable Care Act and all of the national push to do outpatient workups and get patients away from your hospital, get them discharged instead of admitted. I think this, if you can get 20% of your patients for any complaint, especially such a common complaint as chest pain, if you can get 20% of patients discharged who previously oftentimes were getting admitted or worked up, I think that's a really, really big deal, and I think that's going to save a lot of money. So just to summarize what my preferred approach is now, and the approach that we're putting together for our university network here in the Baltimore and Maryland area. If a patient comes in with low-risk chest pain, but you have enough concern to start the workup, what we'll do is we'll stick them into that heart score. We'll get a troponin at time 0 and a troponin at 3 hours. If either of those troponins is clearly positive, then we're done. That person is going to be coming into the hospital. So we're not even using any further elements of the heart score at that point. If both troponins are negative at 0 and 3 hours, and the rest of the heart score is still 0, 1, or 2 or 3 points, 3 points or less, then that patient is risk stratified to a low enough and safe enough level to discharge them, and we're discharging them to get an outpatient workup, and we're not mandating necessarily that they have to follow up within 72 hours. It really depends on the resources at your hospital, but they can follow up within still a relatively short time frame for further outpatient evaluation and further outpatient risk stratification. So I think if you run this by your cardiologist, or run this by your hospitalist, your folks upstairs, and get them to buy into into it, open up further outpatient opportunities. They will endorse it. I think everyone ends up happy. The hospital ends up happy. Patients are happy because they usually don't want to be admitted to the hospital for really, really low-risk things. And you can get more of these patients out. And it's prospectively, externally validated. That means that, as far as I'm concerned, it is a defensible approach. In a rare circumstance where you did end up in court for a rare bad outcome, you would have some really good literature to back you up. And I think, again, it's a very defensible approach to taking care of these low-risk patients. Before I sign off on this, I want to tell you about one more study which we are going to be incorporating into our own University of Maryland network protocol. And I want to credit one of my residents, Brad Cotter, for bringing this to my attention. This is a study that was published from the group at Mayo, and the lead author was Eric Hess, who has done some really great emergency cardiology and observation unit papers in recent years. This was published in a journal that probably most people in emergency medicine never read or would never hear about. It's Circulation Cardiovascular Quality Outcomes. It's published in 2012, so it's not even brand new, but I just found out about it within the past year or so. In this particular study, what they do is essentially they talk about this concept of shared decision-making. The title of the article, by the way, is called The Chest Pain Choice Decision Aid, a Randomized Trial. And again, published in 2012, volume 5, page 251 to 259. If you can get a copy of this article, including some of the diagrams, I would say this is such a fantastic concept and idea. I'd slap myself for not even thinking of doing this a long time ago. I know some of you may be doing something similar already. I think all of us should be doing this, and some of the diagrams and pictures from this article are worth just putting right into your own protocols. Anyway, what these guys did is they essentially provided the patient, after they did the initial workup, they simply told the patient, this is what your estimated risk of an adverse event within the next 30 or 45 days is. How did they come up with that? Well, they could have used a heart score, they could have used the TIMI score, whatever. They came up with a scoring system. They used a validated scoring system and said to the patient, based on everything that we've got, this is what your risk is going to be of an adverse event within the next 30 to 45 days. Generally speaking, they provided this to people who are already at low risk. So let's say they came up with a 1 or 2% risk. They said, Mr. Jones, it appears based on your history, physical, EKG, risk factors, this and that, your TIMI score, your heart score, whatever, you have a, let's say, 2% risk of an adverse event within the next 45 days. We're going to give you a choice of how you want to approach your own care. Well, there's a couple of different options. What we could do is we could go ahead and do an urgent cardiac stress test right now, say from the OBS unit. That's going to require you to be stuck here in the observation unit for quite some time, and then you're going to go ahead and you're going to get the provocative test. Or if you'd like, we can schedule an appointment for you to be seen by a primary care physician or a cardiologist, whatever your resources are within the next 72 hours, or make it a week, whatever you want. Or we can discharge you and you can just go out and make the appointment completely on your own. Or the other choice that they said is, well, if you want, we'll just make the decision for you. And they let the patient have the information. They let the patient decide which of those options they wanted. They had the patient, I think they had the patient sign off on check off what they wanted and then sign off on the form. And what they found was that when they provided this type of information and did this shared decision-making process of over 200 patients that they randomized to the shared decision-making process versus usual care being the paternalistic approach that we always have where we just make the decision for them. What they found was that there's a significant drop in the number of patients who wanted to stay for the OBS and stress test. There was a significant drop in the number of patients who ended up getting the stress test, even as an outpatient, and there were no major adverse cardiac events over the course of the next 45 days. And on top of that, it increased patient knowledge, it increased patient communication. It increased patients' feeling of engagement in the decision-making process. It increased patients' feelings of satisfaction of the whole process as well. And then on top of all of that, President Obama is happy about this also. The authors in this article actually say that in the 2010 Patient Protection and Affordable Care Act, Section 3506 specifically endorses and encourages the shared decision-making process. So even Obama's happy about this whole concept of shared decision-making. It provides the patient exact information, and based on validated scoring systems, it tells the patient what their risk is over the next 30 days, and then it gives the patient an option of what they want to do. The patient checks off what they want to do, and they sign off on the form. And on top of that, what's nice about this article is they give a very visual picture. There's actually one of the figures in this paper where they show 100 people, 2 of whom are colored red. And those 2 people represent the 2% risk in this particular study, the 2% risk of an adverse event. And they just show the patient, this is your risk. And so for people that are not good with statistics, at least they can grasp the concept of a very visual display of what a 2% risk is. I think this is just a fantastic approach to actually having the patient just check off and sign off on exactly what they want. And then this becomes a part of the chart. This is something that we're going to start incorporating. And I think everybody ought to at least take a look at this paper. ERICast, great job to all you folks at Mayo and all of your other colleagues and authors on this paper. This paper really does deserve a lot more attention. It deserves to be put out there in more prominent journals for all of us in emergency medicine, so check that out. So anyway, that is, as of 2014, that is going to be my approach to chest pain. Just understand this is a risk management issue. Again, I don't agree with the guidelines, but what I want more than anything, well, there's 2 things I want more than anything. Number 1, I want patients to do well, but secondly, I don't want people I know in this specialty, I don't want emergency physicians to get sued, and that's a big part of why I've been preaching these guidelines. Not that you have to follow them, but you have to know about them. And now in 2014, I think we finally have prospectively, externally validated studies that will allow you to say, this is the data for why I chose not to follow the guidelines. I think this is a big ray of light for all of us that take care of patients with chest pain. Okay, let's change topics, get away from chest pain and talk about airway. Back this month on EMCast is Dr. Ken Butler. Ken is back to talk about some airway issues, and he's going to be reviewing a recent publication in Journal of Emergency Medicine on trauma airway management. I love short, concise titles like that. The authors were Cheryl Lynn Horton, Calvin Brown, and Ali Raja, all of whom are from Brigham and Women's Hospital in Boston. There is a guy up there who happens to know a thing or two about airway named Ron Walls. But Ron Walls is not an author of this particular paper. And anyway, Ken, first of all, welcome back to the EMCast. It's been a while.
Thank you.
And so we're going to talk about something that you love, and that is airway. And why do we need an article on trauma airway management? It's all the same as normal airways, isn't it?
Oh, that hurt me, Amal. That so hurt me.
All right, well, tell me why I need to know anything special about trauma airway management and what the authors went through, and also your own personal thoughts about managing airways.
Well, first of all, thanks so much for the opportunity. So let's start. The article is well written. I liked it. And it starts with a case. So let's present the case. We'll walk through what kind of happened initially in the case, and then we'll step away from it, as we kind of do in medicine, to say what were our options with this case. And then I'll give you the closure of what happened in the case. So let's go. So this was a 34-year-old male that was in a high-speed MBC. It was head-on. He had front-end collision, and he had a prolonged extrication. EMS's history is that he struck a tree at high speed. At the scene, he was confused. EMS had difficulty getting him on the backboard, and his initial vital signs at that time were his pressure was 110/89, his pulse was 112, his respiratory rate was about 18, and he was sounding at 97% in speaking. The transportation time is classic inner city, so probably less than 20 minutes here in the United States. Comes into the ER, he's boarded and collared, and the physician that initially sees him notices that his voice is getting hoarse, His blood pressure now, initially in the ER, is 95/70. He's becoming more tachycardic with a rate of almost 120, and his sats are dropping down to 94%, and this is on room air. They wound up doing an EFast initially, which shows free fluid in Morrison's pouch. It does not show a pneumothorax. And then they start their secondary survey, which is appropriate. So long story short, on their secondary survey, he has a significant head lac that goes from his forehead to his occiput and is actively bleeding but not hemorrhaging. He has ecchymosis to the anterior part of his neck, and he's got sub-Q air that runs from his neck all the way down to the right nipple of his chest wall. Palpation shows kind of this Rice Krispies or that crunch crunch. And then the issue becomes, where do we go with this patient? They do a bedside chest x-ray, which shows that there's a right middle lobe opacity and no pneumothorax. So the question now becomes, do we see the patient and find out what the internal injuries are, or do we intubate him in the ER?
I don't know. I think it's time for me to sign this patient out.
Well, right. Well, that wasn't an option.
My shift is over.
Oh, you're killing me. You're killing me.
All right. Well, back in my training, they would just say, just tube them. Just tube them. And I guess as a foundation, we'll go with what I learned in residency. And this is a while ago before the current drugs. And so we would typically just go ahead and intubate with a big dose of midazolam and then a big dose of succinylcholine.
Oh, baby. Okay.
All right, Ken's getting diaphoretic now.
Absolutely.
So, okay, but that's what we did, 20 years ago. And so take us up to modern day, cutting edge management based on this article and also based on what you would recommend, because there might be some slight differences here, and sometimes the differences are very worth talking about for educational purposes.
And I think, I'm sure to your audience, but this is my thought about this case. Someone that would have said, well, right now he's holding his own. We all say this to ourselves, and let's get him or her over to CT scan, take a look to see what the bronchus looks like and the vascular structures as well as his neck, and then we'll get him back in the ER. Well, the bottom line of that, as we all know, is that the CAT scanner is not a resuscitation unit. And if things are going sour down there, I tell you from the heart, they're not going to come back in a good pulse. So never, ever send somebody over there. And through all the years that I've been a doctor, I think what makes us good is anticipating somebody's clinical course, and that comes with years of experience. Meaning that, let's just say this man looks well now at time zero, you know in that voice in the back of your head, this is just going to get worse. And securing somebody's airway is key, and in these trauma patients, we need to be aggressive. So that's my first thought about that patient, as I clearly would have intubated him early. So let's look at about this. So our decisions in a trauma airway, let's make this as simple as we can. So we'll step away from the case from just a second. So failure to protect somebody's airway, failure to oxygenate or ventilate. So, and I look at that and I say, well, protection meaning, are they pooling inside their mouth, right? Is there another reason they can't protect their airway? Are they so obtunded from head trauma that they're unable to? Oxygenation, is there an obstruction and they can't get O2 in? And then in this particular case, is there thoracic wall trauma and he's unable to ventilate because he can't do any type of inspiration or expiration? So in protection of airway, one thing that Pearl, that you never want to do in a trauma patient is you decide if they have a gag reflex. It's really twofold of why you should never do that. One,
so never check a gag.
Never check a gag. In a trauma patient, I'll tell you why. Because vomit is the enemy in any intubation. I grew up, as most of your listeners did, that the tongue is the enemy. Well, blades kind of do a good job unless it's an angioedema. But what becomes the enemy is massive vomiting. It obstructs everything. It will change you and the position of your patient. But more importantly, checking for a gag is going to make the patient vomit. And if I was a neurology attending, I would tell you that about 10% of the population doesn't have an intact gag and have no neural abnormalities. So it's not 100%. And more importantly, it increases your risk for aspiration and vomiting.
All right. That's certainly, checking for a gag is one of the things that's often taught in the airway assessment, and one of the things that we're taught to do for the board's purposes as a sign, or as an indication for intubation. Of course, on the boards, you don't have a real patient who's going to vomit. So, interesting. All right, go ahead.
So I think in this particular case, you need to be aggressive. And many people wince when they talk about trauma airways because they think the patient's going to get better. But if you thought about that, secure the airway sooner than possible. Never send anybody over to imaging. The imaging is not going to save a life. You are, because we can do anything in someone who's alive versus having a nick in their pulmonary artery later on. So then our decision becomes, we take this tree and go, well, do we do an awake intubation or do we paralyze the patient? So let's walk down that tree. So if this patient was boarded and collared, trauma patient, we decide, well, maybe you want to, because of this tracheal abnormality, this subcutaneous air, you want to take a look to see what the cords look like. Is there a possible that there's a tracheal injury or a transection? And you want to do an awake intubation. And that's not unreasonable, but what needs to be said is awake intubations are only as good as your fiber optic skills are. If you don't have anesthesia with you, this is no time to be a hero. Calling somebody for backup in these particular cases is the right thing to do. As much as we rarely do that in EM because we are so good at taking somebody's airway. But in a case like this, I would have no trouble calling somebody for backup if I wasn't good at that particular skill.
Yeah, and that's actually a really nice point. I think there's oftentimes a sense in emergency medicine that we need to be the masters of the airway, and that's true. Absolutely. But we're not masters at everything, and I'll be right up front and say that my ability to do fiber optic intubation is not so good. If I've got time, then sure, I can kind of take a look down there, but if somebody is heading downhill rapidly, then I'm not going to succeed with that. Or if somebody has a very tenuous airway, then I'm not the best person to do the intubation. It's time to put your ego aside and really get the most qualified person. And so there's no reason to be a cowboy. If you need a fiber optic intubation and you're not good at it, go ahead and call anesthesia, or in some cases, better yet, call ENT to come and do the procedure. You actually teach courses in laryngoscopy and fiber optic procedures, so I have no doubts about your skill, but I won't hesitate to say that I'm not where you are when it comes to fiber optic procedures.
But Amal, you're so right. Seriously, and your point of this is not being a hero, right? Heroes can die alone, and we don't want that with the patient. If you're not good at a skill, you need to call who is. And this is the classic case, and this paper reflects that, is that you need to call someone for help. So,
heroes die alone.
They do.
I like that.
I know.
You've always got great quotes here. Is that another New Jersey quote? Or?
Could be.
There's other people in Jersey that die alone.
Yeah, this is true. But they're in the back of a trunk.
At the back of a trunk or with concrete shoes.
Absolutely.
Okay, back to the paper.
So let's just stay with the initial tree in the beginning. You're going to do an awake or a paralyzed. We'll walk through them more formally in a second. But here's my pearls on this particular case. Always want to sit a patient up if you can. Now, you can say, well, Ken, you tell me this patient's boarded and collared. I can't sit them up. Oh, that's so true. But what you can do is put the patient in a reverse Trendelenburg. So what are the benefits in a trauma airway and really in any airway of sitting somebody up, particularly in this case? Number one, you're going to decrease the risk of aspiration because he's going to be bleeding somewhere or has edema that's falling because he's got this bronchial fistula that we'll talk about. Two, you decrease ICP because you increase venous drainage from the brain. Neurosurgery, as you all know, would love the head at 30 degrees on any TBI patient. Number three, you decrease VQ mismatching in sitting somebody up, and you actually recruit collapsed alveoli and open them up. So it's kind of a win-win. And number four, which I really didn't throw into this, is that you increase diaphragmatic excursion, meaning that ventilation becomes easier for you, the patient, and the vent. So sitting somebody up, even boarded and collared, is a win-win for the brain, the lungs, and the gut. So let's start with that. That's probably the best pearl I can put so far in time of where we are.
So reverse Trendelenburg should be considered with these intubations. So
Absolutely.
Great pearl.
Absolutely. Thank you. Okay, so we've sat the patient up. We went through that pulmonary neuro GI physiology of why we do that. Second thing we're going to do, we're still in the pathway of whether we're going to do an awake or paralyze a patient, is, I love this, is O's to the nose. Why is that? We all know now that high flow nasal cannula buys us O2 when we produce chemical apnea, right? So we're going to put a high flow, we're going to put the nasal cannula on the patient, put it greater than 15 liters, and leave it on no matter what we're going to do, whether we're going to scope the patient or whether we're going to paralyze the patient and do standard RSI. So that helps us keep our O2 sat high.
So just put that nasal cannula on and turn it up to 11 or turn it up to the max, and that'll actually, even after you paralyze, it still provides some level of oxygenation. So you're going to keep that nasal cannula on with nasal airways. You're going to keep it on if you have to bag them. You're going to keep it on as you're intubating. You keep it on right up until the very end when you tape the tube in. Right. So, okay, good.
Good. And then here's the other pearl that I think that, and I would raise my hand and say I wasn't really good at this in the past, especially as an early attending, is that when you assess somebody's airway, many of us are good at asking the patient to open their mouth, doing mal and potty, looking at maybe this, their thyroid to mental distance. And I'll tell you, that's wonderful to do, and we get a good gestalt of what's going to happen. But what we don't do in every RSI, even in a non-traumatic and elective airway, is always palpate somebody's neck, find out where the cricothyroid membrane is before you ever pass a paralytic or even an induction agent. Because I want to know where home plate is, and two, it forces me to say, hey, where is that cric kit? Is it down the hall or is it right behind me in case I need to go to plan C?
Mm-hmm. All right, palpate the neck.
Always palpate the neck.
Good pearl.
Okay. So let's talk about this particular case. So now you're going to manipulate the neck in reference to the intubation itself. Again, we're still making the decision whether we're going to awake or paralyze. There's a scampit of people that worry about taking off an anterior collar and maybe exacerbating an underlying cervical spine injury. But I will share with you there is no paper and no clinical data that any RSI, whether it was VL or DL or fiber optic, exacerbated any cord issue in a patient with known cervical spine injury. So I think you're safe to say leave the posterior part of the collar on, take off the anterior collar. You're going to do that to palpate the neck anyway, but manipulating anyone with a standard laryngoscope blade or a VL blade or fiber optic has never to date ever made a C-spine injury any worse. So that's a nice kind of breather for me to say.
Yeah, I've seen those lectures where they show fluoroscopies of people getting intubated, and there's really no more movement of the C-spine during the intubation as when the patient is just laying there and other procedures are being done. So it's probably no more harmful or helpful.
Absolutely. Good.
Okay.
I agree. Okay, so now let's touch on some medication because we have to talk about that. Medicines help facilitate our patient to get to where we want them to be to hopefully pass a tube. So in the awake patient, there's no right or wrong in anything that I say. This becomes somewhat of a preference, but there's drugs that lean you to which may be better for this patient. So one, we have a fairly young patient with trauma. We know he has a liver lac on our fast exam, and his pressure is dropping. So across the board, ketamine would be a good choice. In the awake box, ketamine is kind of nice because we would think about even giving somebody initially a sub-dissociative dose of ketamine, meaning that we don't do the standard full dose of ketamine, which is really in an adult about 1.5 mg per kilogram. If you do a sub-dissociative dose, and if you're unfamiliar with that, don't worry about it. It means it's below the standard of dose, but it's just enough to disassociate the brain from the rest of the body, give them a little analgesia, a little sedation, but not enough to put them completely out because you just want to look to see what the laryngeal pathway is to see if there's fractured. That typical subdissociative dose is 0.1 to 0.5 mg per kilogram. So we kept the patient sitting up, or reverse Trendelenburg. We got our scope out. If your fiber optic skills are good, we started with a subdissociative dose. But my best pearl is, if you're going to do an awake intubation, I want that paralytic already drawn up in a lower lock on the patient's IV. So I'm ready to push it. The reason why I say that, please, is because if you're going to Sellinger the endotracheal tube over the fiber optic, you have a full minute just that you need for the paralytic to work before you can really pass the tube. Does that make sense to you?
Yeah.
Am I clear on that?
Definitely.
Great. Okay. So now let's just say you're thinking about doing etomidate. I have a little bit of skepticism on etomidate, so I'm just going to step away from the car, as we say in New Jersey, when they get pulled over for speeding. And here's my thought about it. Etomidate is back in the literature about single-dose etomidate. If you pull that up on the internet, you're going to see a lot of articles. And that initially started when etomidate first came out because some of the EMS providers were looking at single-dose etomidate. But I don't think etomidate is a good drug in this particular box, and I say that because etomidate can cause myocarditis myoclonus. And if that happens in this particular case, you're going to make this patient so much more worse. And you're going to feel horrible that you did that. I love etomidate because we talk about it being so hemodynamically neutral. I may leave it for that hemorrhagic stroke or stroke patients not to drop their blood pressure. But in this young patient, I think ketamine trumps this equation better than etomidate does. So I'd kind of stay away from etomidate just for that particular reason, especially in single-dose etomidate.
And going back 20 years ago, we wouldn't use ketamine in any trauma patients because we always worried about the head. And I think we're kind of beyond that myth now.
And for your listeners that may not know, ketamine now in the data is great for cerebral perfusion pressure. It decreases ICP. And Amal, you're so right. We thought about ketamine in heads like a cartoon character blowing smoke out of their ears and so forth. But now we know that the brain likes it and is so much more neuroprotective. So young person, trauma patients, hypotensive, head injured, ketamine, I kind of fits that as the best we can.
All right, good.
So we've talked about induction agents for both of these cases now. I still think ketamine would win as an induction agent. We talked about it being neuroprotective, hopefully getting this blood pressure up, giving you that trifecta of analgesia, sedation, and amnestic period. And then becomes the paralytic, and I think for our institution, I'm fairly biased. I don't use succinylcholine. I think we can do better, and I don't want this whole podcast to go into that. But my thoughts about using non-depolarizing, hence ROC or high-dose VEC, even in this case, becomes that we look at patients that we initially intubate, and what happens is that we have this very tenacious period after the tube is passed where we have to equilibrate the vent and the patient's vital signs. And what happens in the SUX patient is that because it's somewhat in this 8-minute period, the patients are starting to wake up. And in this particular case, waking this gentleman up is not a good thing because the more the patient is waking up, the more they're desatting, bucking, or biting the tube. If you made that decision to paralyze, I want my patient paralyzed the whole shift. Why is that? Because they can ride the vent and the hemodynamics of intubation and be clear on what's happening provided they're not waking up. So I think rocuronium or high-dose VEC is much safer in this case. And even if you're not a believer of that, if you failed the airway, your rescue ventilation is always better in anybody that's completely paralyzed than waking up out of SUX.
Yeah. So it's always a debatable or a controversial issue, ROC versus SUX. And here at University of Maryland, we certainly are much more of a rocuronium type of institution. I think more and more are moving more towards rocuronium. SUX is great for the OR because if you encounter an unexpected problem, you can always just let them wake up and cancel the case. But in the emergency department, you can't really cancel a case. And once you've committed to this patient's intubation because they're losing their airway, it's kind of nice to know that your paralytic is going to stay on board and give you more time to do other stuff. And I think that's the point that you've made before. You really don't want them waking up because they're going to wake up and still have a rotten airway. So the other thing that we encounter often, which maybe we don't talk enough about, is that in our very sick inner city population, we've got an unexpected number of patients that are hyperkalemic or have other types of neuromuscular problems. And in those scenarios, SUX is not a good choice.
I agree. The risk just isn't worth it. And last, if you're up on the critical care literature, we all talk about this post-intubation hemodynamic instability. And this would just muddy those waters of someone that you've put on the vent initially and equilibrating their cardiovascular system and their pulmonary system if they're waking up and bucking and biting the tube. So I don't want that to mask that picture of something that I may have missed initially just after the RSI piece.
Yeah. The one caveat with ROC and vecuronium is please don't forget the sedation afterwards. It's easy to forget since the patient remains paralyzed. After you get the tube in, don't forget the sedation. That's true for SUX also, but since these patients are not going to start moving around for 20, 30 minutes, don't forget the sedation.
Absolutely. Good point. So let's go back to the paper. The paper really talks about tracheobronchial injuries, and the caveat with this particular paper in trauma airway is that you have to be very careful about this because, one, what has happened in the field is there was this rapid shearing of a mobile lung on a rigid bronchus in this acceleration, deceleration as this young man hit the tree at high speed. So there's a significant shearing force. But what happens is that if you intubate this patient, the potential of you exacerbating that tear or almost 100% occluding it are very, very high. Now, most of these patients die in the field, but when they come to your ER, you need to have a high index of suspicion. So anyone with bruising on the anterior chest, subcutaneous air, and swelling of the neck, you know that's an ominous sign that this airway isn't going to be the typical one that you would do in asthma or just a single closed head. The physical exam for the classic tracheobronchial injury, dyspnea, respiratory distress, well, that doesn't tell me a whole lot because we see that so much, right? They wind up getting this hoarseness because air is tracking and they've lost their typical exhalation piece of their phonation because of the bronchus is torn and they're not getting significant air out. They usually can have a pneumothorax with it, and they usually have significant hemoptysis with it. Now, the gold standard is a CAT scan, which will look at about 70%, but the other 10% come out that those patients need to be bronched. Now, that's not an option to many of your listeners, and it's not even an option to me and you, depending on how ready the pulmonary care team is. So the last thing was paramount in this management, tracheobronchial injuries, high-speed MVCs, blunt chest trauma, deceleration injury, coming into your ER, hoarseness, maybe some neck edema that you initially see, subcutaneous air and swelling, particularly on whichever side it may be. In this particular case, it was right-sided. And what's paramount in management is that these patients may have an initial partial tracheal transection, and you want to avoid making that a complete transection by doing standard, if you will, RSI, if you have options to delay that and to do a fiber optic or visually see the track of the air column before you pass a tube.
All right, Ken, so really nice set of pearls from this paper. Do you want to just take a moment and wrap things up?
You bet, Amal. So here's my thought with this. One, assessment of the airway. I'll leave these lemon or these other mnemonics that people have to look at someone's airway, but please don't stick a tongue blade, especially in our patients in emergency medicine. Number one, trauma patients, not a good thing to do. If there's a risk of bleeding, you're going to make it worse. But more importantly, you're going to make this patient vomit. And more importantly, it doesn't tell you the true neurostatus because many people may not have one. Mm-hmm. Second, sit all these patients up. Good for the brain, good for the lungs, decrease the risk of aspiration if they vomit. 3, in patients that you have any thought that maybe the trachea or parts of the air column are transecting or a partial tear, you need to have someone fiber optically intubate this patient. Your skills, I think, in residencies are getting better, but the tools that you use are only as good as the last time you use them. Calling down to the OR and getting a fiber optic scope and you haven't used it at all and not even know if it leads a light box or not is not going to help you in these cases, right? And then 3, never be afraid to call for help. And that's something that we need to just stop being in testosterone storm about and call your buddies because they're going to help you.
High tea.
High tea. Thank you so much. High tea.
All right. Well, thanks a lot, Ken. Those are some great pearls to keep in mind for the next time you're dealing with an airway, especially a trauma airway. So, all right. Look forward to talking to you again real soon.
Thanks, Amal.
All right, well, next up on the EMCast, we're going to spend a little time talking about a very, very important clinical topic, and it overlaps with risk management and medical legal stuff as well. And it's something that I think is bread and butter knowledge for every resident and every attending out there, and that has to do with informed consent. There was a very nice article that was published in Academic Emergency Medicine not long ago, and the lead author was Greg Moore, who is an MD, JD, and a few of his colleagues were involved in this as well. It's a nice article, and to help us go through this article and also go through this topic in general is one of my colleagues, Dr. Larry Weiss. Larry is very active in our residency program at teaching in risk management. He kind of oversees our residency risk management curriculum. He is an MD, JD. He has spent a significant portion of his career doing in-courtroom litigation, one of the few emergency physicians who has done that. And he's got just a ton of experience over the course of his career in talking about not only medical legal topics, but this topic in particular. First of all, Larry, welcome back to the EMCast. So let me hand things over to you. I know this is something that you've talked about and even written about before, and maybe you can take us through some of the cases that they present, and I certainly wouldn't mind if you throw in your own 2 cents along the way.
Well, thanks, Amal. First, I'd like to congratulate Dr. Moore and his colleagues for writing such a fine article and such a necessary topic. And, before going through the cases, I'd just like to make one general comment. as Amal said, this is a critically important topic because when you look at modern consent law, it essentially gives many plaintiff attorneys two bites at the apple. When you look at these landmark consent cases in most of the states, they started out as ordinary medical malpractice lawsuits that went nowhere. And then, a bright, capable plaintiff attorney got the idea of saying, okay, this wasn't medical malpractice, but the physician did not get proper consent from my patient to do A, B, C, D, E. And that ended up being a winning strategy. I think in general, many clinicians don't pay enough attention to the consent process, and state law in most states says that the most senior physician on a team is the one who should be getting the consent. This is not a medical student activity. So if I'm doing a lumbar puncture with an intern or a resident, I try to go in and get the consent. And I go over the things that I feel are important, and we make sure the consent process is completed in a proper way. The single most important, most valuable thing that they mention in the paper, and they mention it toward the end, is when a patient makes a decision regarding consent. And by the way, refusal is part of the consent process. The patient has the right to say yes or no. And when they say yes, and especially when they say no, you should make some succinct documentation in the chart that the patient has the capacity to understand. Because when a patient makes the wrong choice and still wants to sue you, what do you think their attorney is going to allege? He's going to say that she was so confused that you never should have let her refuse that lumbar puncture or refuse the central line. So the burden is on you. When a patient makes an irrational decision, when a patient makes a wrong decision, the burden is going to end up being on you to show that the patient had the capacity to understand. And that's a simple conclusory statement. It doesn't really have much evidence, but it reflects the art of medicine, that someone with a lot of clinical experience decided that the patient had the capacity, the general capacity to understand. If you're not sure, you do a mini mental status exam. I rarely have to do that, but I at least make that statement the patient had capacity to understand. Okay, so I want to touch on this topic of informed refusal. Like, what do you do with a patient who's very compliant, very cooperative, but they're just going to refuse one procedure? For example, let's say you decide someone needs an NG tube. They have a small bowel obstruction. They're actually vomiting, and they're willing to stay in the hospital. They're going to wait. They're going to be admitted to the surgical service. They say yes to everything. They just don't want an NG tube. You don't make that patient go home. Well, what I usually do is get a general consent form, and I cross the word consent off on the top, and I write refusal. Informed refusal. And I go through the consent form, decide, I document the risks, the benefits, the alternatives, the complications, and I document the patient gave me an informed refusal. Now, in the paper, they do a great job going through the history of modern consent theory. To me, it's interesting, and I think for anyone interested in this topic, it's easy to read, and they do cite some landmark cases. They talk about exceptions to the informed consent doctrine, and in the ED, the major exception is the emergency consent doctrine. If someone comes into the ED with head trauma, they're not competent, they may not even be conscious, you can assume they were brought to the ED for you to treat them or save their life or both. So that's the main exception that's relevant for us. Now, a lot of the cases they go through are not emergency department cases, but it doesn't matter, because when a court makes a holding, reaches a decision on an issue like informed consent, it applies to every single setting. And they review a case called Truman v. Thomas from the California Supreme Court in 1980, and this dealt with a patient in a GYN office that was refusing pap smears, then got cervical cancer, and guess what? She blamed her gynecologist. But she was able to prove that this was not informed refusal. He didn't really document much. He never documented that he informed her of the risks of not getting a pap smear. And so guess what? He ended up losing the case because he was unable to prove that it was an informed refusal. So, it goes back to my example of the NG tube. If someone's refusing a specific procedure, you need to document it. And you might not always have time to go through a whole consent form and document an informed refusal, but somehow you should clearly and definitively document the fact that they refused a procedure and you told them why it was necessary, the complications of not getting the procedure, and they still would not relent and allow you to perform the intervention. Then they talk about a case called Pugsley v. Prevet. a case from the Virginia Supreme Court in 1980. And this case had an unusual fact pattern. A woman consented to surgery performed by her gynecologist, but she wanted her general surgeon there to observe the procedure. And who knows if the general surgeon ever agreed to that. And they took the patient into the OR, her general surgeon wasn't there, and she revoked her consent, and they operated on her anyway. And here the court held that a conscious, alert, competent patient, someone who has the capacity to understand, may rescind or revoke their consent at any time. And this general ruling has been taken to an extreme extent in some cases. There's a well-known case decided by the Wisconsin Supreme Court about 15 years ago where a woman consented to a VBAC, a vaginal birth after C-section for a subsequent pregnancy, and I guess her labor pains were getting too intense, and as the baby's crowning, she changed her mind and wanted a C-section, and they didn't do it. They delivered the baby, and the court held that they violated the patient's consent, that she could rescind her consent at any time, she could change her mind at any time, and the physicians were held with liability for violating her consent. And so in some cases, the court is intruding so far into medical decision-making that it can sometimes be frankly inappropriate. For example, in the next case, Bubb v. Brusky, decided by the Wisconsin Supreme Court in 2007, a patient had a TIA and was sent home, and I guess had a stroke and then sued. And the court held that if there's a choice between getting admitted or going home, that the physician should get the informed consent of the patient. It should be the patient's decision whether they get admitted or go home. I can't imagine Medicare would ever agree with that ruling. I can't imagine any third-party payer would ever agree with that ruling. And this is an unwarranted intrusion upon the practice of medicine. Can you imagine the chaos that would occur if we allowed every patient to decide whether or not they got admitted or they went home? This is an essential part of medical decision-making. This is for the physician to decide, or in this day and age, whoever the licensed independent practitioner is, it's for that person to decide. And, when I read about this case, I was more than concerned. I was angered for many obvious reasons. And then when I looked up the reference, it's an unpublished opinion. And that means that this case has no precedential value and you shouldn't worry about it. This was a wayward decision. And see, when an appellate court writes an opinion, the judges decide whether or not the opinion goes into an official reporter. For example, cases out of California get published in the Pacific Reporter, cases out of Maryland get published in the Atlantic Reporter, and once they get published, other attorneys can cite these cases as precedent. It's actually unethical for any attorney to go into any court and cite an unpublished opinion. There must have been a reason why this court decided not to officially publish the opinion. Maybe the plaintiff attorney did such an extraordinarily good job that he swayed the jury, and then appellate courts will not reverse jury opinions unless they're clearly wrong, unless no reasonable jury could ever come to that opinion. I would think this case would meet that threshold, that it's a very high hurdle to overcome. But I think the authors should have mentioned that, because I think everyone who read this article would have gotten alarmed at this holding, but the actual decision of the case. But it has almost no value because it does not create case precedents. But, a lot of judges, every judge I interacted with really thought they knew medicine, and I don't think I can remember one judge who I thought knew anything about medicine. So they think they understand medicine, and this is a clear case of a panel of judges that did not even have a basic understanding of how medical decision-making should occur, and they came to the wrong decision, in my opinion.
Towards the end, they talk about some consent forms, and I think that's a key clinical point to discuss. What do you think ought to be on those forms, or maybe if, more importantly, what do you think are the key elements that should be involved in getting consent, and then we'll take the opposite end of things, and I'm going to ask you, what do you think ought to be the key elements involved in obtaining informed refusal from patients? What is it that we need to document?
Okay, that's really an essential question, and I'll start out by saying informed refusal is the same thing as informed consent, that the rules for refusal generally should not be different. We go through the consent process, and then at the end the patient says yes or no. So it's the same process. And I think it's absolutely essential that somewhere again, and this justifies repetition. One very good way of teaching and learning is through repetition, and it bears repetition to say that you've got to document capacity to understand. By the way, a case winds up in court, judges get irritated when you say patient is mentally competent, because in most states there are statutes that deal with mental competency hearings, and it always says the judge is the person to decide mental competency. What we assess is clinical capacity to understand. So you should document that. You should document who is performing the procedure. One of the leading landmark cases in Maryland dealt with a cholecystectomy, and the common bile duct was cut, and it was done by a resident. The plaintiff alleged that the surgeon never revealed that a resident would be doing 90% of the procedure. So you've got to explicitly state who will be performing the procedure. It's even good to write that in the consent form. But you basically have a duty to describe the procedure, describe alternatives, describe the risks of the procedure, risks of the alternatives, risks of refusing the procedure. And a well-designed consent form has all that present. And there absolutely should be a place for a witness to sign. And nurses make the perfect witnesses. Nurses are, well educated. They're articulate. Anyone who watched ER on television knows that nurses and doctors argue all the time. We know that's not true. But, I've heard plaintiff attorneys say, oh, you got another doctor to witness your consent form. Medicine is like the biggest fraternity or sorority, and doctors always lie for each other. I've heard several plaintiff attorneys make that allegation. So for so many reasons, I would not get another physician to be your witness, and nurses really are perfect. It's one of many ways that our nurses constantly help us.
All right. Well, those are some fantastic points. And again, this is incredibly important knowledge for all emergency physicians and residents out there, what informed consent and informed refusal are. And so once again, Larry, thanks so much for kind of getting us up to speed on some of the risk management and medical legal topics that are out there that we all face. And I hope to get you back again real soon.
Thanks. Happy to be here.
All right. Well, let me just recap here. Larry has spoken about consent at national conferences before, and I would consider, many others around here would consider him a national expert on this particular topic. And certainly, Greg Moore is an expert on this topic as well. The thing that I wanted to really highlight once again was what type of things need to be documented whenever obtaining informed consent or informed refusal of care. So let's see, there's 1, 2, 3, 4, 5, 6 things that ought to be documented. And I don't have a mnemonic. If there's anyone out there who has a quick mnemonic to help people remember, send it on in, and we will get that out there. But the things that need to be documented, first of all, capacity. Not competency, don't use that word, but capacity. The capacity for that patient to understand what you're talking about. Now, you can be really elaborate and do many mental status exams and all types of other types of point scoring systems that are available, and Larry's actually done EMCast on that particular topic before. But it seems that if you simply put what he describes as a, quote, simple conclusory statement, unquote, in other words, your professional clinical experience judgment that this patient has the capacity to understand, then that tends to be sufficient. But you need to put something in there to indicate that that patient's awake and alert and understands what the heck is going on. So capacity, number 1. Number 2, who's doing the procedure? Number 3, describe the procedure and alternatives. Number 4, describe to the patient the risks and the risks of the procedure. And also, 5, the risks of refusal. So the patient needs to understand not only why they're getting the procedure, but what the risks of getting the procedure are and what risks they are at if they refuse the procedure. And then finally, number 6, the witness. Get somebody to witness the consent, sign. And it's great if it's a nurse. It can be a family member. It can be any other healthcare provider, but nurses are typically perfect examples of people to sign off since they tend to be very involved in the patient care as well. So capacity, who's doing the procedure, describe the procedure and alternatives, describe the risks of getting the procedure, describe the risks of refusal of the procedure, and then get somebody to sign off on all of that. And you don't need to write a whole paragraph about that. That can be a checkoff form. It can just be some simple phrases that you're putting in there. But you've got to put that in there. You've got to document that. Having a form that the hospital has endorsed is great, but get that in there. It's very, very helpful. All right. So once again, my thanks to Larry for discussing informed consent and informed refusal with us once again. And thanks again to Dr. Moore and colleagues for a really great paper. All right, well, that about wraps it up for the November 2014 EMedHome EMCast. Before we sign off, though, I wanted to remind everybody about the Advanced ECG Workshop, which is on EMedHome's website. It's something that we taped. It's about 7 to 8 hours of content. It's worth 10 hours of CME credit. It is intermediate and mostly advanced level ECG content directed at acute care and emergency care physicians. It covers myocardial ischemia, mimics, Brady's arrhythmias, tachycardias arrhythmias, syncope, pearls, pitfalls, medical legal cases, and so on. It is high yield stuff and high risk stuff. It's worth about 10 hours of CME credit. So check it out. It's called the Premier ECG Workshop, www.EMedHome.com. Go to the website of EMedHome and you will see that course posted there for anybody out there that wants to really bump up their ECG skills. Check it out. All right, folks, until next month, I hope you all are well, and we'll have some great topics for you coming up in December. Until then, take care.